this very nice meeting. I shall begin by the recent advances in the management of diabetic macular edema. Why the slides don't change?
Yeah, for changing the slides, doctor, you must tell the while on the website that kindly share the slide. And also please turn on your video so that we can have a good view of your speech also. So kindly share on your video, start the video. Dr. Ahmed, am I audible?
Yes. Yes, I can hear you, but I don't know why the slideshow is not progressing.
Yeah, slideshow, for that, you must say that kindly switch on to the next slide.
I am trying to switch that to the next slide, but it does not.
Okay, wait, let me help you. And also first switch on your video.
I opened the camera now.
Okay, you have opened the camera? Okay, yes. You're visible now.
Yes, but I don't know why the slides are not turning on one after the other.
Yes, actually, you don't have to share the slides. The conference committee will share the slides on their behalf. So, wait, they'll start. They'll start the slideshow.
I'll turn on the slides from my side or tell them next.
From their side, the committee side, they will start the slide. Yeah, now it will be possible. You don't have to worry about it. So it's fine now. It's working.
Yes, but it does not turn on. Any slides are.
Wait. Yes, they are doing it. Yeah, please switch on to the next slide.
Slide.
Yeah, I'm telling the conference. I'm telling the committee people. Yes, now you can start.
Yes. Complications of diabetic macular edema are generally divided into macrovascular and micro. Are microvascular complications actually similar to the diabetic nephropathy and the diabetic neuropathy. Next slide. The pathogenesis of diabetic macular edema can be seen in the next slide, where we can find here a derangement in the metabolism of glucose into several pathways: protein kinase C pathway, the advanced glycation end products pathway, the renin-angiotensin system activation pathway, the polyol pathway. And these pathways lead actually to damage of the endothelial cells of the microvasculature, leading to leakage into the retinal tissue, in addition to narrowing of the lumen of the blood vessels by the disturbed basement metabolism, basement membrane metabolism, and the overproduction of collagen, leading to ischemia. Therefore, there is a combination of leakage and ischemia. Next slide. Next slide. A key factor which is produced because of the deranged metabolism is the vascular endothelial growth factor. Next slide. Next slide. Vascular endothelial growth factor Next, vascular endothelial growth factor is produced because of hypoxia, and this leads to two problems. Next, the first is the stimulation of the microaneurysm formation and the increase in the vascular permeability with the resultant diabetic macular edema. Next slide. Diabetic macular edema can be classified into several classifications. Next slide. Next, a clinical and fluorescein angiographic classification divides the diabetic macular edema into focal diabetic macular edema. Next. Next. Diffuse diabetic macular edema. Next. Next. Ischemic maculopathy and mixed maculopathy. Next. There is an OCT is a new modality for the diagnosis of diabetes and the classification of the diabetic macular edema, and there are several classifications for the diabetic macular edema by the OCT. The first of these classifications takes into consideration the retinal thickness, the diffusion of the edema, the volume of edema, the morphology of the edema, and the presence of vitreous traction. Next. The retinal thickness is measured into the several quadrants in which we divide the macular area, and there are normative data for the normal values in these areas. Exceeding the normal values in these areas causes because of the macular edema can be measured. Next. Next. The extension of the edema also can be measured by the change in the color from the green to the red. Next. Next. And also the volume there are normative data, normal, borderline, and abnormal to diagnose the diabetic macular edema. Next. Next. The morphology. Next slide. In the morphology, there are three main morphological changes. Either the edema is in the form of compact retinal thickening, or it is in the form of cystoid changes in the macula, or in the form of subretinal fluid. Next. Traction on the fifth point is the traction which is present or absent. It might be absent, it might be a tangential traction, or it might be an anteroposterior traction. Next. Next. The second classification takes into consideration, in addition to the thickness and the cystoid changes, it takes into consideration the morphology of the retina itself, the morphology of the photoreceptors, disorganization of the inner retinal layers, present or absent, hyperreflective foci, which indicate or reflect the presence of an inflammatory element in the pathogenesis or not, subretinal fluid present or absent, and the vitreoretinal relationships, whether there is traction by vitreous phase or an epiretinal membrane or so. Next. An unpassed swept source OCT classification takes into consideration the site of the fluid accumulation in the retina, whether it is in the inner layers or in the outer layers. The presence of fluid in the outer layers has a bad prognostic visual effect because of the presence of fluid around the photoreceptors. Next. Next. This is an example of fluid accumulating in the inner retinal layers. Next. Next. And this is an example of fluid affecting the inner and the outer retinal layers. Next. Next. There are also systemic factors that have a role in the diabetic macular edema. Next. Next. The control of the diabetes. Control of diabetes was found to delay the occurrence of diabetic retinopathy and diabetic macular edema. Next. Next. The presence of high serum cholesterol is usually linked by the presence of hard exudates in the macular area. Next. 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 The presence of proteinuria decreases the intravascular oncotic pressure with a net fluid movement into the retinal tissues. Next. In renal disease, Next. The performance of hemodialysis, therefore, usually the disappearance of the macular hard exudates because of the clearance of the proteinuria. Next. Hypertension increases the capillary hydrostatic pressure with a net fluid flow into the retina and increase in the macular edema. Next. Next. It was found that a control of the blood pressure usually decreases the progression of diabetic retinopathy and decreases the risk of the decrease in visual acuity. Next. Next. Puberty. Next. And pregnancy. Both of them have a worsening effect on the diabetic macular edema because of the hormonal changes that occur, and in pregnancy because of, in addition to the high blood pressure in some of the pregnant patients. Next. 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 Follow-up schedules are therefore put if the age of onset of diabetes is less than 30 years of age. The recommended time for the first eye examination is within 5 years of diagnosis and then yearly. If the age of onset of diabetes is more than 30 years of age, therefore, a recommended time of first eye examination is upon diagnosis, then yearly. Prior to pregnancy, the recommended time for first eye examination is preconception or early within the first trimester and then 3 monthly. Next. Another follow-up criteria. Another follow-up, previous one. Another follow-up criterion, which is very important, is the follow-up visits according to the pathology which is present in the retina. The more the pathology which is present, the more frequent the follow-up visits are scheduled. Next. Next. The management of established diabetic macular edema is either by next focal or grid laser. Next. Next. Laser causes damage of the retinal pigment epithelial cell with stimulation of reproliferation of the endothelium of the retinal capillaries and venules, and the adjacent retinal pigment epithelial cells proliferate and form tight junctions. These restore the integrity of the retinal barrier. At the same time, damage of the photoreceptors by the laser eliminates the photoreceptors which are high oxygen consumers, increasing the retinal oxygenation and consequent decrease in the blood flow. Both of these mechanisms decrease the leakage and improve the edema. Next. Next. It was found that focal laser reduces the risk of moderate visual loss by 50%, and the grid laser improves the best corrected visual acuity in 75% of the patients. Next. Next. Micropulse laser is a new modality of laser which does not cause damage to the retinal tissues, but produces the same therapeutic effect. And the advantage of this is that the photoreceptors and the retinal pigment epithelium are preserved, and the process can be repeated several times without any problems with the retina, with consequent improvement in the visual acuity and decrease in the macular edema. Next. 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 The second modality is the use of antivascular endothelial growth factors, anti-VEGF. As we said that VEGF, next. As we said that VEGF increases the permeability of the blood vessels and causes diabetic macular edema. Next year. Next. Increase the vascular permeability causing diabetic macular edema. Therefore, when using anti-VEGFs, we decrease the microaneurysmal formation and increase and antagonize the increase in vascular permeability with consequent improvement of the diabetic macular edema. Next. Next. However, there are several important OCT criteria that say that if they are present, this gives a worse prognosis with the treatment of anti-VEGF. These include the presence of disorganization of the inner retinal layer, the presence of hyperreflective foci, which indicate the presence of an inflammatory component, the presence of hard exudates, the presence of large interretinal cysts, the presence of subretinal fluid, and the damage of the photoreceptors, which is assigned by the ellipsoid zone in OCT, which is absent here in this figure. Next. Next. Clinically, we can predict the response to anti-VEGFs after 3 anti-VEGF injections if the central retinal thickness decreases by 20%, or the visual acuity is gained by 10 letters or more. There is a good long-term response to the anti-VEGF, which is expected. Next. Next. After 1 injection, if there is a decrease in 15%, this also gives a good prognostic criterion. Next. 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 Then we have the intravitreal steroids. All hallmarks of inflammation are seen in the diabetic macular edema. Therefore, steroids are expected to be an important modality for the treatment. Next. Next. By antagonizing the pro-inflammatory cytokine and the inflammation. Next. Next. These are examples of pro-inflammatory factors that are released during diabetic macular edema, leading to capillary non-perfusion and breakdown of the blood-retinal barrier. Next. 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 2 types of steroids are used: the fluocinolone acetonide or the ileuvine insert. Next. Next. Or the ozordex, which is a dexamethasone implant, both of which are injected by an applicator to the inside of the eye, and they remain active for several months, leading to a cure of the diabetic macular edema for a long duration. Next. It was found that dexamethasone has a reduced risk of intraocular pressure increases and cataract progression as compared to the ileuvine, and therefore dexamethasone is the first choice when we are planning to use steroids. Next. 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 Vitrectomy for diabetic macular edema, next, is used when there is traction on the particularly anteroposterior traction on the retina to relieve the anteroposterior traction and return the retina to its normal anatomy. Next. Next. In the absence of posterior hyaloid traction, the use of vitrectomy is controversial. Some say that it leads to the elimination of the chemical mediators such as the VEGF in the premacular liquefied pocket and the improvement in the retinal oxygenation. Next. Next. The algorithm for the management of diabetic macular edema is therefore next. Next. We see by OCT if there is no vitreomacular traction or there is vitreomacular traction. If there is no vitreomacular traction, we have 3 scenarios. First, next, subclinical diabetic macular edema, which is not seen clinically but diagnosed by OCT, and this is managed by follow-up visits, glycemic control, blood pressure control, control of the lipids, cessation of smoking, weight loss, and treatment of the renal impairment. Next. Next. If the edema is non-center involving, that's to say, not under the macula itself, this is the importance of this is that this can progress into center involving diabetic macular edema, therefore it must be treated. The best treatment for these cases is by laser photocoagulation. However, observation and the use of anti-VEGFs is another option. Next. Next. If there is center, previous slide. If there is center involving diabetic macular edema, we use anti-VEGFs as a first line of treatment unless contraindicated, as in cases of a recent cardiovascular or cerebrovascular event within the previous 6 months. breastfeeding and pregnancy. If there is no response for the anti-VEGF, because the pathology, as we saw in the first slides, is very complicated and it does not depend on vascular endothelial growth factor alone. Therefore, we can either shift to another anti-VEGF with a stronger effect or the use of steroids. Next. Next. There are several protocols. Next. 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 Next slide. If there is center involvement, diabetic macular edema in pregnancy, we see if it's clinically significant diabetic macular edema, the safest thing is to use micropulse laser. Green and focal lasers can be also used. If it is refractory to laser, a dexamethasone implant can be inserted. If the diabetic macular edema in pregnancy is mild diabetic macular edema or edema developing during pregnancy, we only observe since the edema may well resolve after delivery. Anti-VEGFs and triamcinolone are better avoided during pregnancy for fear of teratogenicity. Next. Next. If there is proliferative diabetic retinopathy with diabetic macular edema, if it is non-center involved, we use lasers. If the center involved, we use anti-VEGFs followed by pan-retinal photocoagulation. Next. If there is vitreomacular traction, if it is anteroposterior traction, we go straight to vitrectomy. If it is tangential traction, we first try with anti-VEGFs or dexamethasone. If no response, we go to vitrectomy. But the absence of any visible vitreomacular traction, there is no evidence of significant benefit from pars plana vitrectomy. Next. Next. Newer advances to solve the unmet needs in management of diabetic macular edema include predictive medicine, which detects the occurrence of the disease before its manifestations appear in an individual based upon population-based cross-sectional studies. Solving the problems of delayed diagnosis, referral, and screening can be done by using of non-midriatic ultra-wide field fundus cameras, the use of handheld devices, and the use of artificial intelligence. To reduce the burden of monthly anti-VEGF injections, we use longer-acting anti-VEGFs or port delivery system, which we shall see in the following slide. Next. Next. Then we have newer pathways which are probed in order to treat the diabetic macular edema in cases of a failure of anti-VEGFs and steroids to give a response, attacking all the points of pathology in the pathway of the abnormal metabolic pathway of glucose during diabetes. Next. Next. This is the port delivery system which is implanted into the eye. This is the appearance inside the eye, and it is a refillable implant. It can work for months to be refilled once more in an office-based clinic. Next. Next. And these are the various pharmacological agents which are now studied into either phase 1 or phase 2 studies, but not still established as, but have a future application in the near future, inshallah. Next. Next. Then we have drugs which inhibit the renin-angiotensin system, which causes angiotensin 2 and its receptors type 1 and 2 cause retinal leukostasis, advanced glycation and product activities, gene expression of VEGF. Therefore, next. Next. Two drugs, the lisinopril drug and the sartan drug, were studied in various studies, and they were found to have a good effect in decreasing the progression of diabetic retinopathy. Next. Protein kinase inhibitors, next. Next. Are either selective protein kinase inhibitors being studied in clinical trials as this drug, which inhibits protein kinase C beta, decreasing its pathological effect. Next. Next. or an oral administered drugs, which is non-specific protein kinase C inhibitor, but it has many side effects in spite of its effect in reducing diabetic macular edema. Therefore, not used up till now. Next. Recently available drugs in the market. Next. Next. Faricimab is an anti-VEGF. It has a dual action. It is a bi-specific antibody. Next. In addition to being an anti-VEGF, it is an anti-angioprotein 2 drug. Angioprotein 2 inhibits Tie2, which is Tie2 is a very important kinase receptor. It's a tyrosine kinase receptor, important for the vascular stability. Angioprotein 2 inhibits the Tie2. When inhibiting the angioprotein by faricimab, there is activation of the Tie2, and we don't enter into the vascular budding, increasing permeability and stimulation of retinal angiogenesis, which occurs if this drug is inactivated. Second, next slide. Brolucizumab is a very nice and very new long-acting anti-VEGF, but it has next. But it has a complete previous slide. But its complication is that it causes occlusive vasculitis in about 2% of cases. Therefore, it is not administered routinely because of the high untoward effect. Next. Aflibercept, which is now an established drug in the 2 milligram concentration, is now being studied was studied in the photon study in an 8 milligram concentration in order to extend its effect. And it was found that it is very effective. And next. It was very effective in improving the visual acuity, and at the same time, without any.
Yeah, Dr. Ahmed, sorry to interrupt. Dr. Ahmed, sorry to interrupt, but you should proceed a little bit faster. Because we are on slight time. Sorry about it, right?
I have only one slide. Next.
Okay, thank you.
Next. Other future drugs are the aldose reductase inhibitors, the angiotensin, the advanced glycation end product inhibitors, the non-steroidal anti-inflammatory drugs, and antioxidants. Next.
Good day, my name is Flora Chanakchan, and I'm here today to talk about the role of myocardial perfusion scintigraphy in cancer patients undergoing non-cardiac surgery. Did you know that cardiovascular disease is the leading non-neoplastic cause of morbidity and mortality in survivors of breast cancer, Hodgkin lymphomas, and childhood cancer with leukemia treated with radiotherapy or chemotherapy? Understanding the mechanisms of coronary artery disease in cancer may provide insight into how best to prevent it. Cancer survivors with other cardiovascular risk factors are most prone to coronary artery disease, with dyslipidemia, tobacco smoking, and obesity documented as key risk factors. In addition to the traditional risk factors, there are a range of novel factors that are particularly related to cancer and its treatment, including drivers of inflammation and coagulation, which also contribute to the development of coronary artery disease. There are different types of cancer treatment. About 60% of cancer patients undergo some type of surgery as part of their treatment. Surgery often involves cutting out or removing the cancer from the body. Typically, surgery is a good option for cancers that aren't advanced and haven't spread to the other areas of the body. Cancer patients are often older with high prevalence of cardiovascular disease. Furthermore, non-cardiac surgery in this population of patients is challenging because previous administration of potentially cardiotoxic chemotherapy or fibrosis due to previous radiation. Here you can see a summary of patient-related and cancer therapy-related factors that could influence perioperative risk in this population. Several risk indices have been developed based on multivariable analysis of observational data and have been validated during the last decade. As you can see, only in 2 of 5 risk calculators in cancer, cancer is a potential variable. On the other hand, there remains a lack of robust evidence regarding the prognostic value of nuclear imaging technologies like myocardial perfusion scintigraphy before non-cardiac surgery in cancer patient population. So the aim of our study is to evaluate the prognostic value of myocardial perfusion scintigraphy in cancer patients during specific treatment planning, including cancer surgery. Overall, 103 patients were included in our study. The mean age of patients was approximately 69 years old. 2/3 of patients were men and 1/3 women. Approximately half of patients had major cardiac event before, i.e. previous myocardial infarction. Leading cancer localizations were gastric cancer, lung cancer, uterus, and colon cancer. According to the European guidelines on management of patients undergoing non-cardiac surgery, the risk of the surgery was estimated and it was high in 56%, intermediate in 33%, and low only in 11%. The patients were referred to stress rest myocardial perfusion scintigraphy via single computed tomography using 2-detector rotating gamma camera before cancer treatment. Single photon emission computed tomography, ISPECT. Imaging was performed from 15 till 40 minutes after stress test. We used either exercise or pharmacological stress test, and stress endpoints were determined according to American Heart Association practice guidelines. Myocardial perfusion imaging was performed with technician, i.e. maybe attenuation correction was applied during scanning procedure. Semi-quantitative parameters are extracted from an automated program. The heart is divided into the 17 segments, and each segment is scored from 0 to 4, where 0 means normal perfusion or normal uptake of radiopharmaceutical, and 4 means absence of uptake of radiopharmaceutical. Some stress score is obtained from the total amount of scores in all 17 segments in the stress images. This scores was used for estimation of intensity of perfusion disorder in stress. Normal myocardial perfusion was considered if SSS was less than 4, slightly abnormal if it was from 4 to 8, and significantly abnormal if it was more than 9. The degree of ischemia was also assessed on a semi-quantitative basis by sum difference score. SDS less 2 means no ischemia, from 2 to 6 means moderate ischemia, and more than 6 significant ischemia. From 103 patients, 100 patients underwent to stress rest protocol, and only 3 patients we made only rest perfusion imaging because of absolute contraindications to stress test. In 56 patients, we used bicycle. In 30 patients, we used pharmacological test, and 14 patients were used pharmacological test with low-level exercise. We called it so-called combined test. The results of stress test you can see on the slide. From 100 patients, 55 were proceeded to the next stage of cancer treatment after myocardial perfusion imaging without any additional cardiac testing. The rest 48 patients weren't allowed to the next stage. In 18 of them, there was a change in treatment strategy. For example, from surgery, They were turned to chemotherapy or radiotherapy, and 30 of these patients were allowed to cancer treatment due to high risk of major cardiac events. On the whole, some stress score and some difference score representing total myocardial ischemia and infarct by myocardial perfusion imaging are significantly higher in patients who were not accepted to the next stage of cancer therapy. In the subgroup of patients with treatment strategy changes, these parameters were also slightly higher than in patients who accepted to cancer surgery. The extent of stress-induced ischemia was significantly higher in patients who were not accepted to the next stage. Concerning left ventricle ejection fraction, which is also calculated by estimation and diastolic and systolic volumes derived from short axis images in patients who were not accepted to the next stage, and in those who had treatment strategy changes, it was significantly lower. Coronary angiography was performed in 23 patients. 20 of them had high cardiac perioperative risk according to myocardial perfusion imaging. We pay attention that even in patients with negative stress test, the majority were undergone to coronary angiography. It means although the stress test in those patients was negative, there was a perfusion defect of myocardium obtained by nuclear visualization method. I mean myocardial perfusion scintigraphy via single photon emission computed tomography. We compare semi-quantitative parameters in patients whom invasive coronary angiography was made and was not. Some stress score and some difference score representing total myocardial ischemia and infarct are significantly higher in patients whom invasive coronary angiography was made. Similarly, extent of stress-induced ischemia was higher and the left ventricle ejection fraction was lower in above-mentioned patient subgroup. From 20 patients, in 13, there was a hemodynamically significant stenosis of coronary arteries via invasive coronary angiography. We decided to divide these patients to 5 groups according to coronary artery stenosis presence and the severity of stenosis. As you can see, as more intense the severity of stenosis, as higher the semi-quantitative parameters, I mean some stress score and some difference score in these patients. Coronary revascularization was made to 8 patients. Let me show a short clinical case which represents our scientific work. A patient 86 years old with colon cancer had complaints like dyspnea, chest discomfort during exercise. He had atrial fibrillation on ECG. Furthermore, he had diabetes mellitus type 2 and chronic kidney disease of stage 3. We performed him nuclear stress test using vasodilator, which revealed significant stress-induced ischemia of left ventricle lateral wall with arrow on the slide. The patient was undergone to invasive coronary angiography, which showed multivessel coronary disease with obtuse marginal artery occlusion, which is what is the reason of this ischemia. We made a decision to send the patient to the CABG surgery at first. So, in conclusion, I want to say that semi-quantitative analysis of myocardial perfusion abnormality on single photon emission computed tomography is a reliable and reproducible method to evaluate the extent of perfusion defects in cancer patients with coronary artery disease undergoing cancer treatment. Myocardial perfusion scintigraphy, via SPECT, is an effective gatekeeper to coronary angiography as a visual method in patients with high or intermediate risk for major cardiac events. In conclusion, we want to say that myocardial perfusion scintigraphy is an important tool to predict major cardiac events in cancer patients undergoing a different treatment strategy, including surgery, chemotherapy, or radiotherapy. Thank you very much. You can send your questions, if there will be, by email that you can see on the slide.
My topic of presentation is Nutrigenomics in controlling cardiovascular diseases. According to the epidemiological data, says that the leading cause of death is cardiovascular disease throughout the world. An estimated 17.9 million people died from cardiovascular diseases in 2019, representing 32% of all global deaths. The most important behavioral risk factor of heart disease and stroke are unhealthy diet, physical inactivity, use of tobacco, harmful use of alcohol, and hypertension. The effect of behavioral risk factors may show up in individuals as raised blood pressure, blood glucose, and lipid levels in the blood, overweight, as well as the obesity. Obesity and cardiovascular diseases have linked complicated mechanisms which is controlled by genetic and environmental factors, including diet. Cessation of tobacco use, reduction of salt in the diet, eating more fruits and vegetables, regular physical activity, and avoiding harmful use of alcohol have been shown to reduce the risk of cardiovascular diseases. Nutrition is an environmental factor and it has a vital role in managing the health by preventing the obesity as well as the obesity-related diseases, including cardiovascular diseases. Patients to patients have shown a marked variation has been observed even by following the same dietary pattern. This variation explains the genetic polymorphism which developed the concepts of nutrigenetics. Nutritional genomics and nutrigenetics is a field of science which detects the variation in genetic responses. It is associated with specific nutrients and relating their differential responses towards various diseases like cardiovascular diseases, which is also related with the obesity. Personalized diet recommendations based on the knowledge of an individual's genetic constitution might improve the health condition, which is a new approach in reducing obesity as well as the obesity-related cardiovascular diseases. Literature suggested that genes encoding miRNA, APOB, PCSK9, SORT1 cytokines, and IFN gamma are strongly associated with the development and progression of cardiovascular diseases. The aim of this presentation is that how nutrigenomics helps to detect the risk factor and develop a new prevention strategy, and it improves the quality of life through personalized nutrition. So, CVD prevention strategies. So, there are numerous numbers of nutrients which is associated with the CVDs. So first one is the fruits and vegetables. What should be the intake capacity or how it can be varies from person to person. Various fruits and vegetables contain a wider range of antioxidants, nutrients, vitamins, dietary fiber, folate, flavonoids, different antioxidants and vitamins, which have been associated with the reduced risk of cardiovascular diseases. It is widely tested that higher consumption of fruits and vegetables is having a protective role against the cardiovascular diseases. As well as along with the fruits and vegetables, nuts is also a very important dietary factor which can also alter the responses of the genes, and it will varies from the person to person. As nuts contain high amount of fat, but most of the fats are good in nature. They are basically monounsaturated and polyunsaturated. Numerous metabolic studies have found that a diet with high in nuts, just like peanuts, walnuts, almonds, and various other nuts which can be found throughout the world, which significantly lower the LDL level of cholesterol and decreases the ratio of total to high density lipids cholesterol. Besides the favorable effect on blood lipids, nuts may protect against coronary artery diseases through other mechanisms. Most nuts are rich in arginine, which is a precursor of endothelium-derived relaxing factors, nitric oxide. Nitric oxide is an potent vasodilator. As we all know, nitric oxide is a very good signaling agent that can inhibit the platelet adhesion as well as the aggregation. They contain high amount of magnesium, copper, folic acid, potassium, fiber, and vitamin E. After that, we can consider the whole grains. We cannot say that all refined grains are good. Refined carbohydrates are as well as sugars are not good as a good plant-based diet for each and every person. So if we consider in our meal whole grains, that can be much better in comparison to the refined sugar or refined carbohydrates. So whole grain products such as whole wheat breads, brown rice, oats, barley usually have a lower glycemic index value in comparison to the refined grains. Whole grains are also rich in fiber, antioxidants, vitamins, magnesium, and phytochemicals. The lower risk associated with a higher whole grain intake was independent of intake of fiber or several other constituents of whole grains. The nurse health study observed a 25% lower risk of cardiovascular diseases, within that the coronary artery diseases, among women who ate nearly 3 servings of the whole grain a day compared with those who ate less than a serving per week, as it is reported by Liu et al. 1999. After that, we can consider the fats or oils. The major nominal sources of monounsaturated fat include olive oil and canola oil, nuts and avocados. Both canola oil and nuts are also important source of polyunsaturated fat. Some vegetable oils such as canola and soybean oils contain high amount of alpha-linolenic acid, an essential omega-3 fatty acid important in the prevention of cardiovascular diseases. The nurse health study, as reported by Hu et al. 1999, found that higher consumption of oils and vinegars adding salad dressings, as it is a major source of alpha-linolenic acid in the US diet, was strongly associated with a lower risk of cardiovascular diseases. I can also include one important thing with this respect of fats and oils, that is ghee, which is not a plant-based diet or product, but if you add in your diet on a regular basis, as it comes from the animal origin, then also it is a very good source of fats and oils, and it can help to burn the fat, as we can say it as a fat burner, and it can also prevent the cardiovascular diseases. The cholesterol lowering benefit of plant-based protein source like soybean and pulses from different sources throughout the world and nuts is well documented. The overall cholesterol lowering benefit of plant protein is in substitution for animal protein as meat, dairy, and or egg alternatives has not been reported. The available evidence from randomized controlled trials suggested that 1 to 2 servings of plant protein in substitution for animal protein decreases lower density lipoprotein cholesterol in respect to non-high density lipoprotein cholesterol and apolipoprotein B by 4% in adult and with and without hypolipidemia. Choline and L-carnitine compounds derived mainly from animal foods such as red meat, poultry, and fish are broken down by gut microbes to generate trimethylalanine, which is further broken down to TMATO in the liver. TMA2 has been associated with a higher risk of cardiovascular events. Likewise, standardization should also include cutoff point for good intake and or dietary components. Without previous standardization, replication of gene-diet interaction will be very difficult to achieve. Although this seems to be a minor problem, we cannot forget that nutrigenomics study also require a good quality control and validity of the genetic determination. Gene-diet interaction could be one of these causes of heterogeneity observed in studies involving different populations. In this case, the same genotype may have a different responses or effect on immediate phenotypes or clinical outcomes depending on the dietary intake. If we give them same diet schedule or chart for a set of time frame, then also we can see the same genotype containing people can show different kinds of responses. So before going to some kind of conclusion, so we have to know first the hereditary, the genotypic or gene pool study, then we can understand what is the pattern of their dietary intakes, and according to that, how their genes are responding. So nutrigenomics cannot be rigorously applied to cardiovascular prevention and treatment at this time, and important results are being generated that will serve as a basis to increase the consistency of future research, which in turn will achieve the necessary level of evidence. At that point, nutrigenomics will become a reality in dietary personalization in cardiovascular medicine and subsequently in optimizing cardiovascular treatment and prevention. So there are few studies which is related with the gene diet interactions, which determining that how this kind of interaction may help in the prevention of the cardiovascular diseases. So here are few studies. There are lots of genes are there, and they are responding according to the person to person and along with their diet intake. So few studies are done by Fumeron et al. 1995 in myocardial infarctions, Marcus et al. 1997 in ischemic cerebrovascular diseases, Wu et al. 2000 coronary artery diseases, Hinz et al. 2001 myocardial infarction, Yates et al. 2003 thrombotic events, Vionis et al. 2005 coronary heart diseases, Coronis et al. 2006 in myocardial infarction, Volik et al. 2007 coronary heart diseases, Young et al. 2007 myocardial infarctions, Bruce Narvaez et al. 2007 myocardial infarctions, Colonellis et al. 2007 myocardial infarctions, Ali et al. 2008 myocardial infarctions, Jensen et al. 2008 myocardial infarctions, and many more. So nowadays, before conclude these presentations, there are lots and lots of studies are there in this respect of gene diet interaction. So there is a different contradictory result also, and few scientists and doctors are also saying that there is no relation in between the plant-based diet as well as the animal-based diet, which is linked with the genetics or gene. But in few cases or majority of the cases, you can say that there is a link in between the diet, what they are intaking on a daily basis, and how their genes are responding. But it is too early to say that only the factor diet is involved in the development of the cardiovascular diseases or pre-existing cardiovascular diseases. So we can take it as a way or path so to prevent the cardiovascular diseases as well as the medicinal pathway or surgeries what the doctors are already developed in their laboratory, and they are doing on a practical basis in their hospitals. So there is a lots of study is still the things are not very clear. So in future we can also explore the potential of healthful plant-based diets, or in few cases we can include the animal-based diet also, and it's totally based upon the the genomics of that particular individual, which improves the improvement, which can also help to improvement of the nutrition-based genomics, as well as a secondary prevention among patients with pre-existing cardiovascular diseases, as well as due to the sedentary lifestyle development of the cardiovascular diseases. And it totally depends on the individual's gene diet interaction pattern and the recommendation by the doctors of personalized nutrition by studying the hereditary gene pool. These are few of the references, and thank you for
one of the research fellows currently working in the UK. So I'm here to present a very unusual case report, but with a very important impact in cardiology. So it's a multi-drug resistant Salmonella endocarditis of a native fowl. I'll start with how the case presented, and slowly as the slides go on, I'll explain what was unusual and how it impacted treatment in cardiology. So we had a 25-year-old male of South Asian descent presented to us with complaints of productive cough for 45 days, high-grade fever for 30 days, with shortness of breath for 30 days, and recently started hemoptysis for 30 days. Fever was high-grade, chills, rigors with night sweats, and the patient responded to antipyretics. Now, his past history was, the significant part was that he was an ex-smoker with 5 packs per year smoking history. Now, the interesting part was that he was currently at the time working in a TB center as a ward boy with a strong TB contact history. His family history was insignificant. Now, on his general examination, we found no significant findings of anything that could lead us to diagnosis of a fever, while this patient was having fever for the last 1 month, high-grade fever. So there was no like clubbing or no like rod spots or anything that would lead us to any immunological phenomena. So his vitals were normal except his increased temperature. On his precordial examination, we found out he had an end-diastolic murmur in the aortic 2 area. And on respiratory examination, he had wheezes, bilateral mid-zone crackles. And in the abdominal examination, we found he had a palpable spleen. Now, we did an extensive investigation for the patients because initially we were having a lot of patients coming to the hospital with enteric fever that were multi-drug resistant enteric fever. And based on that and giving his strong TB contact history, we did investigations and excluded TB. So what you're finding, what recently had been happening was that in the hospital, we were getting enteric fever that were multi-drug resistant and sensitive to ceftriaxone and meropenem. So we actually straightforward started this patient empirically on those 2 antibiotics, considering local guidelines for the enteric fever, the resistant enteric fever. Well, the conventional treatment of enteric fever had been fluoroquinolones, macrolides, but it was not working in our population, and the cultures were saying also otherwise. So now these were the lab markers of the patient. If we can see on admission after 48 hours and discharge, on discharge. So if we can see the white blood counts were raised, HP was fine, platelets mildly raised, liver function, not significant change. Although on admission, his serum albumin was a bit low, and then his creatinine was also fine, along with his urea mildly elevated. His inflammatory markers were also raised, CRP raised, ESR raised, LDH raised, procalcitonin raised. And we did all the TB tests and we found no TB detection. So the interesting part was the culture sensitivity that came back positive. So 2 sets of culture, there was persistent sets of culture coming positive for heavy growth of Salmonella paratyphi. This is just a blur picture of a culture, and you can see the sensitivity to imipenem, meropenem, ceftriaxone, and it was resistant to cipro, trimoxazole, chloramphenicol, ampicillin, what you call the multi-drug resistant, and intermediate sensitivity to azithromycin. So traditionally, Salmonella, still in the guideline paratyphi, is treated with fluoroquinolones and macrolides, and also ceftriaxone. But we were getting a high input of patients who were resistant to all those and sensitive to the imipenem, meropenem, and ceftriaxone. But the story doesn't end here. The interesting part was what we found. If we look at the HRCT, it shows a disease progressive. If you look at this CT chest, It shows bilateral dense multilobular shadowing on the background of ground glass opacification with interlobular and intralobular septal thickening. So there have been some sort of infective process also going on. So it was a bit of an unusual diagnosis as what the patient could be going through. So the differential diagnosis could have been pulmonary tuberculosis, infective endocarditis, although it would have been an unusual one, rheumatic fever, enteric fever, and vasculitis or / connective tissue disease. Now, the echo finding was the most interesting one because on echo we found multiple aortic valve vegetation, severe aortic regurgitation, and moderate mitral regurgitation. So now the arrow could show you the small multiple aortic vegetations. So the case we have been discussing is obviously infective endocarditis, but let's discuss how unusual the findings were in this case and how prompt treatment of this case prevented the life of this patient. So usually we diagnose infective endocarditis on a major criteria or modified STU criteria. So we have like major criteria in which we get 2 positive blood cultures that are typical organism or persistent bacteremia, or we get 1 positive blood culture for Coxiella burnetii or antiphase IgG, antititer greater than or equal to 1:800. Or we got evidence of echo showing any vegetations, myocardial abscess, new partial dehiscence of prostatic valve, new valvular regurgitation. So we had persistent bacteremia with this patient, we had positive blood cultures, and we have vegetations on echo. Now we have 5 minor criteria of fever, of vascular phenomena. Now this patient presenting hemoptysis with lungs involving shows of pulmonary infarction. His immunological phenomena, the kidneys were not involved, no ocular nodes, rod spots could be found on an examination. Positive blood cultures not meeting the major criteria, and serological evidence of an active infection. Now the diagnosis is made if you have any 2 major, 1 major or either 3 minor, or you have 5 minor criteria. And we met 2 major criteria here, persistent bacteremia and evidence of vegetations on echo. That's been settled. Now it's a bit of things in this slide is like the most common organism involved in infective endocarditis is basically staphylococci, but what the studies has been showing is hair strep, but it's actually staphylococci that's been the most common organism with 26.6%, and this is then followed by streptococci and then followed by the enterococci. Now the percentage, the burden of gram-negative bacteria is very rare, as you can see the arrow highlighting it. It's up to 0.01 to 2.9% the burden of total bacterial endocarditis due to Salmonella or gram-negative endocarditis. It's very rare, but the story doesn't end here. If we go back into literature and since what do we call it, 1976 up till today, there's some big studies have been done, and we have only accumulated only 87 cases of infective endocarditis due to Salmonella. And all these cases have been primarily because of the Salmonella species, but the non-typhi species basically. Now, there were 87 cases of typhoid and non-typhoid Salmonella. So 42 cases, and then 30 cases in 1986 to 2002, 15 cases in 2003 to 2014. Now, what was different in our case was that in the previous cases, the mean age of disease presentation due to Salmonella endocarditis was in the 6th decade of life. But in our case, the patient was a young patient in his 3rd decade of life. Now, in the previous study, the major affected valves were the mitral valves. Not only that, in the previous studies, the valves affected were either damaged valves, rheumatic fever, or prostatic valves, but in our case, the patient had a native valve endocarditis. Now, mural endocarditis and perivalvular abscess were notably in nearly 1/4 and 1/3 respectively of the cases as part of complication, because if you have Salmonella endocarditis, it carries a high mortality with mural endocarditis and perivalvular abscess as complications, and it needs prompt, aggressive antimicrobial therapy. So the overall prognosis of those 87 reported cases up to date have been a mortality rate of 42.5%, a very alarming rate. And there is no optimal treatment for these complications yet. If we go to the clinical management, if patients develop such complications, it's potent antimicrobial therapy with or without surgical intervention, with a mortality rate as we initially mentioned. So noteworthy that more than 1/4 of salmonella-infected endocarditis will develop mural endocarditis in comparison to intracardiac abscess caused by Staph aureus, with mural endocarditis had a mortality of 52%. So the clinician should be aware of this rare and potentially fatal endovascular complication of Salmonella bacteria. But in our case, since we already started based on our local guidelines, the patient on ceftriaxone and meropenem empirically, and the cultures were sensitive to it. So the patient actually improved. The antibiotics were continued for 2 weeks, and patients showed significant clinical recovery, even though the studies say otherwise regarding the complications and everything. Now, the interesting part is, as I mentioned earlier, it's being a native valve makes it a more different story than the previous one. And not only that, the previous study has shown the species of Salmonella involved in infective endocarditis has been primarily Chloriasis, Typhimurium, Enteriditis as the serotypes, and some other ones. And there has not been much talk about Salmonella typhi. But more interesting is I couldn't find any reports on Salmonella typhi endocarditis that has been multiple drug resistant, that has not been responding to the local guidelines or the local microbiome, whatever we see in the guidelines nowadays. So, as it says that our patient, however, responded well to medical therapy and survived the event to complete resolution with only directed by the culture and sensitivity report. So my discussion point to carry home was Salmonella endocarditis may be a rare etiology, but in the context of multiple drug resistance and extreme drug resistant pathogens that are prevalent in our province, that would be, the study was conducted in Pakistan, it should be a cause for concern as virulent streaks like the one reported have the capacity to infect native valve, could wreak havoc on the already existing and growing number of patients with previously damaged valves and those with prosthetic valves due to rheumatic fever. Therefore, clinicians should be vigilant when treating Salmonella infections. So in conclusion, this case report underscores several critical points regarding Salmonella endocarditis. It highlights the trend of Salmonella strains exhibiting extreme drug resistance, posing a formidable challenge in clinical management. The involvement of native valve, particularly the aortic, instead of the more commonly affected mitral valve, accentuates the variety of this condition and the need of a comprehensive diagnostic approach. Important, early detection of complications arising from Salmonella infection as endocarditis assumes paramount significance because we normally see Salmonella manifesting as some sort of GI symptoms. So Salmonella coming as endocarditis is not as common. This case serves as a reminder of evolving clinical landscape of Salmonella infections and the importance of tailored and vigilant clinical strategies.
So my name is Dr. Mohammed Al-Hussein. I'm an internal medicine incoming resident at Detroit Medical Center, Wayne State University. Today, I'm going to present to you our systematic review, which talk about the role of automated external defibrillator use in out-of-hospital cardiac arrest, the survival rate and outcome. So here are the contents of this presentation. So we're going to walk you through all the 6 sections, starting from the introduction, then the methodology, followed by results, then discussion, and finally the conclusion. And you get to have the references at the end of the presentation. So before we talk, we need to define some terms and to make sure that you're familiar with them. So cardiac arrest. Cardiac arrest is a life-threatening event that occurs suddenly and unexpectedly. Improving survival chances is crucial for rapid intervention within the crucial minutes after cardiac arrest. Defibrillation, which involves delivering an electric shock to the heart, is a well-established and successful technique for restoring a normal heart rhythm, which ultimately reduces the negative health effect and death rate associated with sudden cardiac arrest. So what are public access defibrillators, also known as the bystander use for defibrillators? It referred to the use of automated external defibrillators to treat out-of-hospital cardiac arrest outside the emergency hospital setting. by individuals who are not part of the conventional emergency medical services. The availability and prompt utilization of defibrillators outside hospitals have been a persistent challenge. And why is it important? Because it's used to treat out-of-hospital cardiac arrest, which is a significant cause of death. For example, here in the US, we have more than over 350,000 occurring annually in the US, resulting in a survival of only 8 to 10%. So the chances of survival significantly increases to 50 to 74% when immediate defibrillators with an on-site AED is available. In recent years, there have been increasing recognition on the importance of public access to defibrillators in improving outcomes for out-of-hospital cardiac arrest. Nevertheless, evaluating the overall effect of having widespread access to AEDs on these essential outcomes, such as morbidity, mortality, and survival, continue to be a central focus within the emergency medicine discipline. In this study, we evaluate the impact of public access defibrillators on the outcome of out-of-hospital cardiac arrest. Particularly, we're going to discuss the survival rate and the neurological outcome associated with it. So next is the methodology. As you can see, the methodology is the instructions and the cooking and the ingredients for this presentation. So we're going to give you the details that will allow you to get the same results. So here, as you also can see in the middle of the screen, these are the 5 components of our presentation. Methodology, eligibility criteria, selection process, data item, data collection and quality assessment, and finally is the synthesis method. So here is, first is the eligibility criteria, which is divided into 3 main components as displayed on the screen: PRISMA, PubMed, and Covidence. What is PRISMA? PRISMA is the systematic review was structured with reference to the preferred reporting items for systematic reviews and meta-analysis, also known as PRISMA guidelines for reporting, and we adhere to its principles. Then PubMed. PubMed, all the studies included here in our systematic reviews were imported from PubMed, and the inclusion criteria were studies who experienced out-of-hospital cardiac arrest from the year 2000 to present, and studies conducted in all countries with out-of-hospital cardiac arrest and availability of public access defibrillators. What is Covidence? Lastly, Covidence is the platform that we use to screen these studies. So Covidence was the platform for screening and data extraction of these studies included. Secondly is the selection process. So how did we look up for our studies? The search strategy included keywords and mesh terms related to out-of-hospital cardiac arrest, public facilities access, and defibrillator use and related keyword. Studies reporting on inpatient cardiac arrest cases or were conducted before the year 2000 were excluded from these systematic reviews. So we were able to come up with 345 studies, which we all imported to Covidence and displayed on Covidence. So how did we handle the data on Covidence platform? So 2 individual reviewers initially screened the first set of titles and abstract of studies. In cases of conflicts or disagreements, a consensus was reached through discussion and issues were resolved. We began by screening these studies against their abstract and title, resulting in the exclusion of 188 studies. After that, we assessed the eligibility of 157 studies by reading the entire text. We end up with 30 studies that met our predefined criteria for inclusion. Data item. The systematic review collected a range of data items to thoroughly assess the outcome of interest. For the outcome, we focus on comparison between bystanders, also known as public use of defibrillator, public access defibrillator, use of AEDs and emergency medical services. Data item included survival rate and neurological outcome. So how did we conduct the data collection and quality assessment? For this systematic review, we carried out with a standardized approach using the online tool Confidence. Two individual independent reviewers were responsible for data extraction, and conflicts were resolved consistently. Simultaneously, another pair of reviewers independently conducted the quality assessment for the extracted data to make sure that all the data included are lack bias and are suitable to be included in this systematic review, using strengthening the reporting of observational studies in epidemiology, short-term as STROP framework, to ensure adherence to best practices. Templates following the PRISMA guidelines were utilized for both data extraction and quality assessment. Finally, the synthesis method. So we employed the narrative synthesis method as the primary approach for synthesizing the evidence. To facilitate the presentation and synthesis of the data, we utilized Microsoft Excel as a valuable tool. The data were meticulously organized and displayed in bar charts. This approach was chosen to enhance the comprehensibility and accessibility of the study results, allowing for a clear and a concise representation of the finding. This methodologic choice was made to ensure that readers can easily grasp and interpret the sensitized evidence for informed decision-making. So next is the results. Before we give you our detailed results, I need you to look up on the left side of the screen. You will be able to see the PRISMA flow chart for this systematic reviews. As you can see that we started by 345 studies at the beginning, and then primarily we excluded 188 in the first part of the screening. After that, we excluded 127, ending up with only 3 studies that are included in this systematic review. So here is the first graph of our result. As you can see here, the figure represents the survival rates between the public access use of AED and the emergency medical services. If you look at the bar chart, you will see that on the x-axis we have the study ID, and on the y-axis we have the survival rate. You will be able to notice that the blue bar charts have a higher survival in all of the studies included, i.e. the bystander survival was higher in all of the studies included. The only difference is the percentage of survival difference between the two groups, which some studies have a substantial and a significant difference, while other studies have only minimum differences. Here is the second bar chart, which represents the neurological outcome between the emergency medical services and the bystander or the public use of AEDs as well. As you can see here, the same representation, the study ID against the neurological outcome, you would also able to see that the neurological outcome of the bystanders were higher in all of the studies included as well. So finally, the discussion. So this review synthesizes data from various global studies on the role of bystander and emergency medical services interventions, primarily focusing on AED usage during out-of-hospital cardiac arrest. The result of this systemic review following PRISMA guidelines underscore the critical significance of public access defibrillator in improving survival and neurological outcomes in out-of-hospital cardiac arrest settings. The present investigation provides significant insights into the effectiveness and the challenge associated with the deployment and use of public access defibrillators in various settings. Starting with the epidemiology, the global statistics suggest that a substantial portion of cardiac arrest occurs at home, with a 59% of out-of-hospital cardiac arrest occurring in private residencies. However, the odd ratio of survival of 1.75 odd ratio suggests a significantly higher chances of survival when an AED is used in public areas compared to instances where it's not. Also, the statistics from Japan further emphasize the life-saving potential of public access defibrillators, with increasing PAD use being directly associated with better neurological outcome following ventricular fibrillation out of hospital cardiac arrest. The location and how does it influence the outcome? Another retrospective study conducted by Frank et al. On the location of non-residential out-of-hospital cardiac arrest in the city of Pittsburgh over 3 years. The implications for AED placement aim to identify the sites of out-of-hospital cardiac arrest that occurred in non-residential areas of Pittsburgh and to ascertain if there are specific high-risk locations where the installation of AEDs could be beneficial. The study showed that between January 1, 1997 and December 31, 1999, the city of Pittsburgh experienced 97 out-of-hospital cardiac arrests. 59% of them were in private homes and 41% were in non-residential areas. So now here, the bystander versus the emergency medical service intervention. Most recent research emphasized that survival benefits of early intervention by bystander. For example, the study done between 2008 and 2015, the Kayahara et al. Showed that use of publicly accessed AEDs together with bystander administered CPR in school boosted survival rate by roughly 4 times for children, school children indicating faster defibrillation by bystander than emergency responders. Also, by combination of the data provided, it's evident that combination of bystander CPR and the use of AED significantly increased the odd ratio of survival to 1.75. This result suggests that bystanders equipped with both CPR training and AED can significantly impact patient outcome positively. Even when bystander did not provide CPR but used AED, the survival was found to be 17 compared to 9 when no intervention was applied at all. The 30-day survival. A study in Denmark evaluated the 30-day survival rate, aiming to identify the percentage of out-of-hospital cardiac arrest cases when an AED was used before ambulance arrival. OHCAs with an initially shockable risk, the 30-day survival was 64% when an AED was used before ambulance arrival, and 47% when no AED was used. This finding also underscores the importance of immediate on-site interventions using AEDs. The neurological outcomes, which was part of our systematic review result. So the life-saving potential of rapid intervention during cardiac emergencies is crucial, and the PAD has played a critical role, particularly outside of hospital settings. Recent research have highlighted its efficacy, especially among school-age children who experience ventricular fibrillation. The study has indicated that those children who were administered the shock by a bystander using a PAD displayed a notably better neurological outcome compared to those who waited for emergency medical services. Recent research from Japan as well has shed light on the advantage of using AEDs in public areas. The study found out that AED in public setting resulted in a more favorable neurological outcome following OHCAs caused by ventricular fibrillation than when it's used in a residential location. So what are the implications and limitations of these studies? So the implication is the benefit of early CPR and defibrillation emphasizes the importance of widespread training in CPR and AEDs, placing AEDs prominently in public areas, especially in high-risk zones such as train stations, can boost survival chances, and regular tracking of OHCA out-of-hospital cardiac arrest, to remind me one more time, especially in densely populated areas, will help in the strategic placement of AEDs and specialized training initiatives. While the current data are robust, further research studies on subgroups such as children can fine-tune recommendations, morbidity, and mortality. What are the limitations of this study? Is that the variability in data collection method and the study demographic may lead to inconsistent conclusions. Some studies found no clear link between AED use and sustained return of spontaneous circulation. The benefits of PAD were less evident in unwitnessed out-of-hospital cardiac arrest or non-cardiac cases. Although OHCAs in educational settings showed better outcomes due bystander aid, adjusted survival rates were similar to public places. Other results, such as an unchanged 30-day survival for non-EMS witness out-of-hospital cardiac arrest or inconsistent EAD benefit, highlights a potential confounders. A comprehensive approach combining PADs, CPR training, and swift emergency medical service response is necessary. Further research should focus on specific subgroups, training impact, and factors influencing AED availability. Finally, this is the conclusion of our study. It concluded that it reminds everyone about the importance of immediate response, particularly from bystander, in improving both survival and the outcome, more specifically neurological outcome here in our studies for out-of-hospital cardiac arrest. The finding also emphasized the significance of raising awareness, providing training, and ensuring easily accessibility to AEDs in public areas. Those interventions have the potential to improve chances of survival and overall result of out-of-hospital cardiac arrest. Therefore, it's essential to focus on the widespread use of CPR and AED training, strategically placing AEDs in public areas, and consistently monitoring intervention and outcomes to enhance survival rates and neurologic recovery after out-of-hospital cardiac arrest. A final words that I want to say, which are out of the presentation contents, is that I have seen recent studies talking about the use of drones to transport these defibrillators from one place to another. And we all agree that time is a crucial factor when it comes to cardiac arrest and returning the hemodynamic stability. For me personally, I think with the development in AI and technology, we might need in the future to study build in the defibrillators in smartphones, and that would be the most reliable and the fastest way to deliver a shock and save a person's life. Thank you everyone for listening.
Rayanne Ely. I am the Division Chief for Pulmonary Critical Care in the Institute for Academic Medicine at Charleston Area Medical Center in Charleston, West Virginia, in the United States. Today, I'm going to present about our research here at the institution regarding a complication for post-COVID syndrome that includes specifically sinus tachycardia after COVID that has been persistent for several months after infection, and really the outcomes related to that post-COVID syndrome. So as we all know, the pandemic of COVID affected many people, 7 million cases, more than 7 million cases by the time of this study was done, with more than 7 million deaths worldwide. Post-COVID syndrome is a syndrome that includes symptoms of COVID-19 that are persistent for longer than 12 weeks after infection. So more than 3 months after infection, patients still have some symptoms of COVID. It can affect up to 35% of individuals, but actually 85% of hospitalized patients may still have symptoms of COVID more than 3 months after their initial infection. This can include a huge myriad of different symptoms, including fatigue, dyspnea, olfactory dysfunction. We often hear about patients having brain fog or difficulty with their memory, as well as other symptoms like musculoskeletal weakness and respiratory difficulties. Sinus tachycardia is also noted in patients that have post-COVID syndrome, and the prevalence can be as high as 20%. Vaccination came out and was started to be administered in early 2022. More than 13 billion doses of vaccination were administered at the time of this study worldwide. Vaccinations have demonstrated a decrease in hospitalizations and mortality, but the effect on post-COVID syndrome with vaccinations is really quite unknown. So the questions that we evaluated in this study was, what exactly is the prevalence of sinus tachycardia in post-COVID patients 12 to 16 weeks after their initial COVID diagnosis, so 3 to 4 months after their initial infection with COVID-19? What is the correlation of that post-COVID symptom with healthcare utilization, specifically looking at intensive care utilization, ventilator use, and mortality? And also we wanted to look at what the benefits of vaccination might be in outcomes with regard to that healthcare utilization as well. So in order to study this, we use the Trinetics database. It's a globally federated health research network with de-identified data from electronic medical records. It includes a ton of information with diagnoses, procedures, medications, laboratory data, and genomic information. With more than 76 organizations globally, it's actually the largest COVID-19 data set currently available. The Trinetics COVID-19 Research Network, we queried the network looking for those patients that were hospitalized adults with a confirmed prior SARS-CoV diagnosis, confirming it with a PCR laboratory evaluation. Our subset of patients included patients from January 20th, 2020 to February 14th, 2022. And we wanted to ensure that they had sinus tachycardia while patients were hospitalized between 12 to 16 weeks after their initial diagnosis. We excluded those patients with a history of arrhythmias, valvular dysfunction, acute myocardial infarction, acute stroke, anemia, hyperthyroidism, adrenal insufficiency, shock, or pheochromocytoma. And that's really to try to exclude those patients that may have another secondary cause of tachycardia for their admission. From that cohort, we divided our patients into 2 subsets or cohorts of patients, those with tachycardia, defined as an average heart rate greater than 100 during their hospital stay, and those patients without tachycardia, again, 12 weeks after diagnosis initially. The tachycardia group was further subdivided based on their vaccination status. And so we had a vaccination group or a completely vaccinated group, those patients that were documented to have a full series of either the J&J or Moderna vaccination, and then those patients that were incompletely vaccinated. So those patients that did not have the full initial series. We then took our cohort of patients and created a propensity match scoring cohort to account for potential confounding factors of demographics and comorbidities. We used those propensity matched cohorts to do a logression to obtain a listed propensity scores, and then our model included age, race, key comorbidities, including hypertension, diabetes, COPD, heart failure, obesity, nicotine dependence, a history of stroke, and body mass index. We had a cohort of patients with tachycardia 3 to 4 months after infection, and those without. And then again, those were further subdivided in the tachycardia group for those that had a primary series of COVID-19 vaccination and those who were not vaccinated at all or only partially vaccinated. Again, that was defined as 2 doses of Pfizer or Moderna vaccinations or 1 dose of Johnson & Johnson, Janssen, Novavax, or AstraZeneca. We then looked at outcomes at 1 year following that diagnosis, we looked at mortality and utilization of critical care resources, including admission to the intensive care unit and ventilator use. We'll look at the results now. So before propensity match scoring, our cohort included almost 1.4 million patients. 2.2% of patients, so 30,000, more than 30,000 patients developed tachycardia. 97.8% did not. When comparing those two cohorts, patients that had persistent tachycardia had higher rates of comorbidities. And really, it was all of comorbidities that you looked at across the board. The ones that were most significant include hypertension, with double the rate of hypertension in the tachycardia group. Diabetes, again, more than double the rate of diabetes in the tachycardia group. And nicotine dependence, almost 3 times the rate of smoking in the tachycardia group. After we did propensity match scoring to find 2 well-matched cohorts, we ended up with 30,700 patients in each group. And those patients were matched for all of the demographics that we listed previously. The mean age of patients was 43 years old. Females were slightly more than half of the cohort at 57%, and Caucasians represented 61% of the patient population. You can see here before matching, we had a fair number of significant comorbidities in the tachycardia group, including hypertension, coronary artery disease, heart failure, COPD, diabetes, nicotine dependence, obesity, and history of stroke. After matching, that p-value is now no longer significant, and they are well matched for their comorbidities. When looking at mortality, we looked at Kaplan-Meier curves to determine the significance of tachycardia versus no tachycardia. And mortality was significantly higher, with a relative risk of 2.4, having a 5% mortality with tachycardia developing 3 to 4 months after initial infection. And that mortality, again, is at 1 year. If you did not develop significant tachycardia with post-COVID syndrome, your mortality was only 2.1%. We also looked at the use of critical care resources, including ICU admission and ventilator utilization. Both of these were also significant in the tachycardia group. Again, more than double the amount of critical care services at 1 year, with a relative risk of 2.6, 5.8% versus 2.2%. And ventilator use was more than 3 times at a relative risk of 3.32. You can see the ventilator utilization was 1.8 versus 0.5% in the non-tachycardia group. We then further subdivided our tachycardia group into those patients that had vaccination, a complete vaccination series, versus those without. Before matching, there were a few things that stood out, with males being slightly more in the no vaccination group. They're not, it's not a very significant number, but it is statistically significant at 43.1% versus 43.7%. We then matched our cohorts with 2 well-matched groups with 7,400 patients in each group. With our vaccination results, we had 75% of patients that had documentation of vaccination series one way or another. 35% of patients were vaccinated, whereas 65% of patients were not vaccinated or were only partially vaccinated. Mortality was significantly higher without vaccination, showing almost 6% of mortality at 1 year without vaccination in the tachycardia group versus 2.3% with vaccination. They also had higher utilization of critical care services, 8.3% versus 3.6%. And higher ventilator use, 3.8% versus 0.6%. So we demonstrated in this study that the persistent tachycardia 3 to 4 months out after COVID infection is about 2.2%. There are other studies demonstrating in SARS-CoV-1 infection in 2006, demonstrating a higher prevalence of 40% of persistent tachycardia. However, this was only 3 weeks after initial infection, which is relatively close in proximity to initial infection, whereas ours looked at 3 to 4 months out, 12 to 16 weeks. There was another study looking at SARS-CoV-2, so COVID-19, prevalence of post-COVID tachycardia with a prevalence of 20%. However, their threshold heart rate was actually lower at 90 beats per minute. Tachycardia is defined as a heart rate of more than 100. And so I'm not sure why they chose this threshold that was lower, but that may explain why their prevalence was higher in that cohort. We did demonstrate that patients that have comorbidities have a higher prevalence of post-COVID tachycardia or post-COVID syndrome with tachycardia, including hypertension, coronary artery disease, heart failure, COPD, diabetes, smoking, stroke, and obesity. Approximately 53% of the world completed the initial series of vaccination in February 2022, which is around the time when our study ended. Most of our patients, 65%, were not completely vaccinated or not vaccinated at all. Those patients that were not vaccinated had a higher mortality, ICU admission, and ventilator utilization. This is consistent with studies showing that vaccination does decrease ICU admission. However, there have been inconsistencies in data showing mortality benefit for different populations. Our study does have several limitations. Inherent limitations include selection bias and differences in care-seeking behaviors with an international database. Our database is also subject to coding accuracy and completeness of data, as well as lack of granular data, getting down to the information as to why patients were admitted is quite challenging in a database such as this. It's also subject to reporting accuracy. There are secondary gains to being fully vaccinated versus reporting not getting vaccinated at all. And so we really depended on patients reporting their vaccination status accurately. And one of the limitations is based on that without being able to have independent confirmation or verification of their vaccination status. And as you all know, there were multiple strains of COVID, and the ability to divide those substrains is not available within this database. And also treatment impact is quite challenging to assess as well. Studies with inappropriate sinus tachycardia unrelated to the viral infection usually demonstrate a similar underlying mechanism as those for the proposed mechanism for tachycardia as a result of COVID-19. Many studies support that autonomic dysregulation is a key underlying mechanism with a blunted negative conotropic response. And so medications such as Coreg, carvedilol, or ivermectin have been noted to improve COVID-related tachycardia. Further study may be interested in studying the effect of these negative conotropic medications, not only with how well they control that symptom of post-COVID syndrome, but also the effect on outcomes. The effects of COVID-specific therapies such as steroids, Paxlovid, remdesivir, tocilizumab, and others have not been studied for this particular post-COVID syndrome component. And identifying modifiable risk factors such as tobacco use and obesity should also be evaluated in post-COVID syndrome as far as outcomes. That concludes our study in post-COVID syndrome and outcomes related to the COVID-19